Hello again, and welcome back to the Oncology Brothers podcast as we continue our hematology series. I'm Rahul Gosain, and along with my brother and co host, Rohit Gosain, today we're tackling the complex disease of myelofibrosis, where we've seen some new treatment approvals, but we still have a lot of work ahead of us.
That's right, Rahul. Myelofibrosis can be complicated as it can manifest itself primarily disorder, or it can develop from other myeloproliferative neoplasm, which is known as secondary myelofibrosis, and can also be seen in conjunction with MDS, if it was not complicated enough already. To guide us through the latest in diagnosing and managing both primary and secondary myelofibrosis, we are joined by an expert in this field, Dr. Naveen Pemmaraju from MD Anderson Cancer Center. Naveen, thank you so much for being here with us today.
Thank you, Rahul and Rohit, and thank you for the Oncology Brothers. I love your work to raise awareness and issues, particularly for our rare blood cancers. Thank you.
Oh, that's very kind of you, sir. We continue to learn from people like yourself. Thank you. Naveen, before we dive into this complicated algorithms, we'll just start off with some basics here. To just put a stage in front, if you have a referral with mild cytopenia and splenomegaly, the diagnosis that comes right in our head is, after we have ruled out all the nutritional and all the benign aspect of it, myelofibrosis or MDS. Any particular initial workup and testing in this particular patient? Are there any vital diagnostic criteria that we need to be aware of?
Yeah, fantastic question and a great place to start. I really love the differential, and I love that you reminded us to think about benign as well as malignant causes in the cytopenia setting. So absolutely great workup. You know, as you get into the malignant heme space, as you said, this is a huge differential. The difference between MDS and MPN myelofibrosis is everything: prognosis, treatment, etc. I think the three things I would remind folks is a bone marrow biopsy is still essential in 2024 to diagnosing these conditions. Not always the easiest thing to do, not always the most popular, sometimes difficult given age, performance status, body habitus. But really, WHO, ICC, we really need a bone marrow biopsy to tell the difference. Number two, your laboratory values, CBC, of course, with the differential and chemistries can really tell you a lot about what's going on, either cytopenias or, proliferative disease, blasts, basophils, lymphocyte count, etc. And then finally, I would say the third piece of this is the clinical picture. The patient can tell you the story. I think with all of the high-tech stuff that we have and all the algorithms, it's my plug to remind people that the social history, the HPI, really listening to the patient. I was playing 36 holes of golf 1 month ago. Now I'm so tired, I'm in a wheelchair. These tell you about something beyond what the labs and numbers can tell you and can point to a trajectory and actually can help you deciding treatment. So I would say those three things to start off our discussion.
Naveen, thank you for setting that stage. And exactly to what you've said, part of this thing is looking at the labs, but the bigger part is the patient in front of us. So now in this hypothetical case that you get referred from your primary care physician, you have your bone marrow biopsy, you have peripheral smear, you've also gone forward with cytogenetics. What are you looking at? How are you going to confirm your diagnoses? And how are you going to risk stratify these patients? Because the next thing that patients are going to ask us are, what are we looking at? What are the prognostic factors here?
Yeah, excellent. So the diagnosis of myelofibrosis for most of us in 2024 encompasses what you said. So for diagnosis first, in addition to what we said, let me throw out there that a molecular analysis, I would actually say, is essential in 2024. The big three driver mutations, to remind our viewers, are JAK2 V617F. That makes up about 50-60% plus of these myelofibrosis patients, so the most common. Number two, the CALR mutation, calreticulin. And then number three is the MPL mutation, MPL thrombopoietin receptor, about 5 to 7% of the cases. So in addition to cytogenetics, also let's include the molecular. So now you have your profile. You have the white count, for example, anemia number, constitutional symptoms from the patient themselves, blast count, etc. In the beginning, when I first started, we had only the IPSS. This is from 2009, Cervantes et al. In Blood, even before the era of JAK inhibitors in the clinic. That was meant actually at the time of diagnosis with several clinical factors. Again, white count, anemia number, peripheral blast, constitutional symptoms, and age. So those 5 factors, but it was meant to be at diagnosis. Now, as we move into the modern era, We now have several more risk scores that many of us use, the DIPS, DIPS Plus, and now most recently the MIPS, MIPS 70, MIPS 70 Plus 2.0. And everyone always says, what do all these IPs stand for? Well, the first letter tells you MIPS is actually very smart. It's Molecular International Prognostic Scoring System. Yes, we do use it in the clinic, and there's an online calculator that can help you. Essentially, team, we're looking at the clinical factors that we mentioned, plus some of the more molecular factors, bone marrow fibrosis, for example, CALR mutation, yes or no, high-risk molecular mutations, yes or no, including outside of the big three, so ASXL1, EZH2, et cetera, putting it together in a scoring system. And I want to be able to tell my patient, their family, and my team, are you low risk, intermediate risk, or high risk? And some of these scoring systems differentiate in between there. Then once you have your risk stratification, then you can start to form a therapy paradigm based on that. And what I would say before I pause here is you're trying to ascertain two things. One, does this patient need treatment at all? Yes or no? So are you the lowest of low risk? Let's identify those patients. And two, are you transplant eligible? Yes or no? Then we can pause there and kind of get into that. But that's what I'm talking about for diagnosis and prognosis.
Thanks for summarizing it so well. Now we know for a fact that high-risk patients, wherever we can transplant, we're going to go for it. And that's where we have to partner up with our tertiary care and quaternary centers. When you talk about intermediate, again, if the patient is eligible for transplant, again, that conversation is being taken place. We in community have to worry about very low risk, and intermediate where they need supportive management. What does the supportive management looks like in particular terms of anemia, thrombocytopenia, and leukopenia? Are we relying on erythropoietin stimulating agents, TPO agents, or growth factors?
I love the way you guys summarize this complex data. It's a really practical, lovely way. So I hope people out there listening appreciate how great you guys are at doing that, summarizing this. So you nailed it, right? So after we get away from the p-values and the scoring systems, what you said is the key. I want to emphasize a couple of nice points you made. One is that the only curative modality for intermediate to high-risk myelofibrosis is allogeneic stem cell transplant, period. So you nicely brought that up. Let me second that. And so, as you said, whether you're at a center or not that does transplant, identify those patients, get them referred. Obviously, we know that's a whole separate process. So I like that you said that. Number two, now let's go to the other end of the spectrum. There is a group, it's a significant portion of our patients with myelofibrosis. They're either post-ET, post-PVMF, as you said, secondary, or de novo, that are actually so low risk that they actually score either 0 or even 1 point on these scoring systems. Guys, that's a group of patients that may possibly be able to be observed. They may not require upfront cytoreductive or chemotherapy approaches, and they can be managed with, as you say, supportive care. Some of those supportive care agents have evolved over time. The main problem for our patients in the clinic is anemia. So if you have mild anemia, maybe not transfusion dependent, there are certain agents that you can use. Previously, we used to use agents that were a bit more available, such as danazol, as you know, steroids, prednisone steroids, EPO injections. Now in the modern era, we're borrowing from some of the other tumor types. Luspatercept is an agent that is FDA approved in some other settings, including MDS. And we do borrow that data to use in our patients with MF regularly. That's called off-label use. It is in active clinical trials, phase 2 and 3, and we eagerly await those data. And then regular old blood transfusions for patients who need it. So supportive care, that's one aspect of it. For platelets, quite difficult, actually. There haven't been a lot of agents. Sometimes people bring in the eltrombopag and romiplastim, but at that point, if you're really both anemic and thrombocytopenic, you need to be thinking about disease modification, and potentially those patients are bumped up to more intermediate risk. Finally, the in-between category, which may be the majority of our patients, we'll talk all about, I'm sure. You're right. You want to decide clinical trial or not. That's an important aspect. Standard of care or not for these JAK inhibitors. And then are you doing stem cell transplant or not? And that may be based on donor type, patient preference, availability, but more and more transplants becoming available all over the world. So we want to emphasize, if a patient can go to transplant, let's get them there and go for a cure if they qualify.
Naveen, thank you for going over that. I'm going to jump on the same bandwagon with you and Rohit. For us in the community, we need to partner up with transplant centers to ensure this curative option, that it has been considered, that the patient has been at least evaluated in these settings. The other thing I also want to bring up, you had mentioned the prevalence of JAK2 mutation, which will take us to that next step of discussion. I want to bring up this because there's this notion that if you're not JAK2 positive, you cannot use JAK2 inhibitors. Naveen, do you mind talking a little more? A patient that is not transplant eligible, and now we're planning to treat them, be it because of their anemia and thrombocytopenia or progressive disease. We're thinking of bringing up some JAK2 inhibitors. We have a few. We have ruxolitinib, momelotinib, fadratinib. Where are you using these? Some of key side effects that we have to worry about.
Yeah, what a perfect segue. So in diagnosis, I think the JAK2 mutation and, of course, the CALR and MIPL can help to just make sure, is this an MPN or not? There is some prognostic significance. There was a study that was done independent of everything else that if you have a CALR mutation alone in myelofibrosis, perhaps those are the better prognosis patients as a solo mutation. JAK2 and MIPL, maybe a more intermediate prognosis, and then with the so-called triple negative, where you're negative for all three, maybe a bit worse prognosis, and most of those patients will have some other mutation, ASXL1, EZH2, et cetera. So for diagnosis, we know. For prognosis, there's some benefit. Interestingly, as you mentioned, brilliantly, maybe, guys, if this may be the only thing people get out of our discussion today, I want to highlight what you said. These so far are not JAK2 mutant-specific inhibitors. They are JAK inhibitors, JAK1, 2, or JAK2 selective inhibitors. So you're right. So what that means is it's inhibiting the pathway that's aberrant. And so, yes, it does work in JAK2 mutated, CALR mutated, MIPL mutated, triple negative. It works in all of these patients because it's the pathway, not the mutation. So I'm glad you mentioned that. As a side note, if people would like to know the future and the research, now finally in 2024 and beyond, we're working on mutant-specific inhibitors. So JAK2 mutant, type 2 JAK, CALR mutation, but that's all in the phase 1 research. So yes, these drugs work for all comers essentially. Now, moving to the JAK inhibitors, I'd like to give you an overview of the 4 FDA-approved agents for your audience, and let's review those in detail. So the overview is this. Number one, the first and longest running JAK inhibitor is known as ruxolitinib, JAK1, JAK2 inhibitor, approved now over a decade ago. That was the Comfort 1 and 2 trials, gentlemen, that showed in New England Journal that either versus placebo or best available therapy, that the ruxolitinib JAK inhibitor given upfront to intermediate high-risk patients with myelofibrosis was superior to either placebo or best available therapy. FDA approved, interestingly, on the basis of a novel endpoint that we still use today called SVR35 at week 24. So spleen volume reduction, 35% by imaging at week 24, and a secondary endpoint of TSS, total symptom score, 50% reduction. So that's the first JAK inhibitor. The second JAK inhibitor is a bit more recent, actually, the next two, the next three, and that was fadratinib. Fadratinib was approved in August of 2019, and this is the second JAK inhibitor on the market. Again, a JAK1/2 inhibitor, really, which is focusing, again, on spleen volume reduction, symptom benefit, again, tested in the front line, but also after ruxolitinib. So that's an important point for the fadratinib. It does carry a black box warning of encephalopathy, previously thought to be Wernicke's encephalopathy, but now known as more of a general encephalopathy syndrome, so watching out for GI and thiamine. The third JAK inhibitor, even more recently, can you believe it, is that of pacritinib. So that's just in 2020, February of 2020. And the pacritinib agent represents not only the third JAK inhibitor, but a very specific indication, which is for platelets less than 50. Okay, so that's important for people to note in the frontline setting. And then a fourth JAK inhibitor, momelotinib, more recently approved. That's September of 2023. And that one also has a special indication, which is myelofibrosis with anemia. So maybe I'll pause there for some discussion. These are the 4 FDA-approved JAK inhibitors, kind of slightly different approvals, and let's see what questions you have based on that.
Thank you so much for summarizing this. There's so much to capture here. So talking about particularly anemia, that's the most common thing we see in community. Now you have started this patient on maybe is now transfusion dependent after EPO has been exhausted. We know the choice here is ruxolitinib or momelotinib. And pacritinib is out for thrombocytopenia. Now, how are you unpacking that, especially with now one can derive this indication for luspatercept from MDS as a result for off-label? How to decide out of this and what to make out of this?
Yeah, I have to say, this is where the field is grappling with. So I think your point is well taken, which is not all anemia is created equal. Not all anemia originates from the same place. I personally would give the viewer some guidance like this. I think anemia comes in different flavors. One for our patients could be the myelofibrosis disease itself. So that's progression of the disease. And in that setting, that you need to do a bone marrow biopsy, repeat assessment to see if the disease is actually progressing. So not only a change of therapy, but maybe a change of disease state. Maybe the anemia means that the disease is progressing. Advanced MF, MDS-MPN, as you said earlier, AML. So let's just make sure we say that. A second category is anemia of other causes. Much more common is iron deficiency, as you said at the top, B12 deficiency, colon cancer, age-appropriate cancer screenings, thyroid, et cetera, et cetera. So let's make sure we're working up for that. And then maybe a third bucket is treatment emergent anemia, which is actually what you're asking about, which you're right is a huge issue. What we noticed with the ruxolitinib in particular, the first in class approval, is it's a highly effective agent, but particularly in the first few months, you can have a real anemia. You can have a drop in the hemoglobin, which is both expected, but also it does require some kind of management advice. There's a couple things to say with that particular JAK inhibitor. One is it's coming, so some of it could be permissive. If it doesn't result in transfusions or symptoms, watch it, dose adjust, keep moving. Number two, if it is resulting in transfusions or management issues, again, dose reduction, watching this. And then number three, know that it's transient. If the anemia persists, then what's interesting is you have the second line options for what we call so-called cytopenic MF. So either at the beginning or, as you say, treatment emergent. If you're not having recovery, you're not having disease progression, it's still chronic MF, then you're thinking about these second agents, the pacritinib, the momelotinib, which both act through ACVR1. So they help to try to improve the anemia. And then finally, you have these secondary agents that we mentioned earlier, the luspatercept addition. Some people add danazol, pulse dose steroids. Each patient is different. But I think that's our summary point here, is that not all anemia is the same, and you really need to work it up. And then based on that, you can manage it.
Thanks, Naveen. In terms of splenomegaly particularly, ruxolitinib definitely helps out with that. Particularly any utility with momelotinib helping or assisting from splenomegaly standpoint?
Oh, we get asked that a lot. Great question. So interestingly, even though the indication for momelotinib is MF with anemia, importantly, it was tested in that setting. So this is the Momentum study that I'm quoting to your viewers, phase 3 study, momelotinib against danazol. And in that study, people sometimes forget, it does in fact show spleen benefit, symptom improvement, and the secondary endpoint is the transfusion independence anemia improvement. So the good news is it's a JAK inhibitor, but because it inhibits this ACVR1, this other pathway that Rux and fadratinib don't hit, it potentially has that extra anemia benefit. So yes, it does improve that as well.
Naveen, we've touched on some side effects. Ruxolitinib, of course, can cause fatigue, anemia. Fadratinib, we have to worry about encephalopathy and monitor thiamine. Any unique side effects that we have to worry about with momelotinib or pacritinib when we're giving this in our clinic?
Thank you very much for bringing that up. So let me just give a quick overview of all of them. So ruxolitinib, there's three that I'd like to highlight. One is the occurrence of opportunistic infections such as herpes zoster or other viral infections. Rarely there's been cases of TB and other things reported. Number two, guys, is that of non-melanoma skin cancers. So that's basal cell, squamous cell. I would say that almost all my patients with MPNs end up having to see the dermatologist. It's just a common part of our field, either the disease process or the agents. And then number three, it's important. Some people can get weight gain, sometimes profound, sometimes 20 to 40 pounds. Desirable, if you will, in an advanced cachectic MF state, not so desirable maybe in PV second line therapy. So that's with the ruxolitinib. Fadratinib, we mentioned the encephalopathy, Wernicke's GI signal. For the other two, as you said, yeah, there's some unique side effects to pay attention to. Pacritinib had some signal early on, a low amount of patients that may have possibly had either a cardiac or a bleeding signal. And so that is something you have to watch out for, particularly patients who are going for a surgery on anticoagulants. So something to watch out for. Also, some people with pacritinib can get diarrhea. It's usually a self-limited first 4 to 8 weeks. So pay attention to GI. And then the momelotinib in the early clinical trials had a signal for peripheral neuropathy, variable, maybe anywhere from 10% or higher. So that's something to watch out for. Again, the GI signal is there, loose stools, diarrhea. And then with all of these JAK inhibitors, you can get a little bit of myelosuppression, right? So it can still cause the counts to go down before before they come up. So I think that's kind of a general rule of thumb.
Naveen, there's so much to cover and we can continue to go on and on, but just because restricted with time, we wanted to thank you so much for taking the time to provide this comprehensive overview on myelofibrosis in such a short period of time for our community audience. For our listeners, let us quickly recap some of the key points we covered today.
Myelofibrosis is indeed a complex and challenging blood cancer, but today's discussion with Dr. Naveen Pemmaraju from MD Anderson has shed some light on the current treatment landscape. While an allo stem cell transplant remains the only potential cure, we now have seen several options to better control symptoms and disease progression.
It is important to keep in mind that patients benefit from JAK inhibitors irrespective of JAK2 mutation status. We do have to be cognizant of some unique side effects, as we have also covered strategies to manage these when it comes to the drugs that are available to us. Then, supportive care, including erythropoietin stimulating agents or luspatercept to preventing blood transfusion, can be very critical. Thank you for joining us. Make sure to check out our other episodes in hematology series covering CLL and myeloma. We are the Oncology Brothers.